So we are moving to our third group for today, Pembroke Psychological Services and Valhalla Vision's Counselling Clinic on the steps the federal government should take to ensure the highest quality mental health programming for veterans released from the military due to illness or injury. And we have Ahamed, Clea, Corman, Bianca, Mammarella, and Noémie, Veilleux. I was more focused on the Noémie because that one I've learned, Veilleux. And as with before, it's the same system. We will give the team 30 minutes. We'll have 10 minutes or so for our jury, and then we will allow our sponsors and audience to come in. Take it away, team.
Thank you, everyone, for being here today. As Professor Welsh just mentioned, we'll be talking about how the federal government can improve mental health for veterans and presenting what we have as recommendations in our Veterans First policy brief that we've developed in collaboration with our sponsors, Valhalla and Pembroke, who have been essential in this process.
We just want to cover a quick disclaimer first. Today we're going to talk about sensitive topics such as trauma, PTSD, or even sexual violence. So we understand it may raise some difficult or uncomfortable feelings for you. And we please invite you to step out very freely if you need to. And we're also available at the end of the presentation if you want to talk.
So, as Professor Welsh mentioned, our policy challenge question is as follows. What steps should the federal government take to ensure the highest quality mental health programming is provided to veterans released from the military due to illness or injury? And we'll be providing context for the recommendations that we'll be putting forward. So I'll pass it off to Al.
His name is Sergeant Mark Evans. He was 41 when he took his uniform off for the last time. Not by choice, but due to injuries sustained over 17 years of service. Mark served 2 deployments overseas. He supported his unit through natural disasters at home and also trained hundreds of young recruits. Back home, he found himself dealing with an invisible issue, an invisible enemy: post-traumatic stress disorder, PTSD, anxiety, and isolation. After discharge, Mark was told help was available, but that help, it took over a year to arrive. While waiting, his condition worsened. His spouse took unpaid leave to support him. He couldn't return to work. The phone calls, the paperwork, the confusing system, it all became a second battlefield. What made it harder was the sudden shift from this rigid structure of military life where expectations, roles, routines are clearly defined, to the chaotic uncertainty of civilian life, where he was expected to be independent, navigate complex situations, and rebuild his identity with little guidance. This dramatic transition only intensified with trauma. For someone trained to operate in a system of order and cohesion, the lack of structure outside of the military wasn't just disorienting, it was deeply destabilizing. When he finally entered Canada's new rehab system, he was assigned a new clinician with no military experience and limited trauma training. The support felt cold, it was robotic, and very unfamiliar. Mark's story is not unique, however. He is one of over 2,500 veterans medically released each year in Canada due to injury or illness. He's part of a generation where nearly 1 in 4 veterans under the age of 55 report PTSD, anxiety, or mood disorders. He's part of a system that is struggling to catch up with the complexities and specialized needs of veterans compared to civilians. Needs that do not just begin with injuries, but with a profound and often jarring transition. Veterans are not only recovering from what they've experienced, but also from what they've lost: routine, purpose, camaraderie, and even clarity. In 2021, a new system termed Partners in Canadian Veterans Rehabilitation Services, or PCVRS, was designed to fix old problems within national rehab programming by integrating physical, psychosocial, and vocational care under one roof. But what we've learned is that the integration has come with a lot of costs: longer wait times, higher clinician dropout, and reduced veteran choice. Only 13% of veterans are currently accessing vocational care, even though loss of identity and purpose are some of the hardest parts of leaving the forces. While virtual care has definitely bridged distance, many veterans, especially older or rural ones, feel misunderstood and disconnected. Crucially, the system is still underestimating the psychological impact of the transition itself. Leaving the forces isn't just about exiting a job. It's about leaving behind a way of life built on structure, trust, and clear direction. Civilian life demands a different set of skills, and many veterans feel unprepared for the sudden shift towards independence, ambiguity, and isolation. It's a steep learning curve, and without targeted transitional mental health support, the curve can break people. Most troubling is that care takes over a year and a half for a veteran like Mark to start receiving. In that time, trauma deepens, relationships erode, and opportunities vanish. These systematic barriers raise the fundamental question, one that has guided our work today. What steps should the federal government take to ensure the highest quality mental health programming is provided to veterans who are released from the military due to illness or injury? To answer this question, we began by carefully studying the existing system, listening to the voices of veterans and mental health providers, and identifying the barriers that prevent timely, compassionate, and culturally competent care.
Now delving into the methodology that we followed through to build our comprehensive recommendations. As Al mentioned, we began our approach with a systematic literature review, focusing on the following 4 databases to enrich our understanding of the research within this field and look into different gaps that research has explored to further our understanding of where our recommendations would be best suited. We then followed through with stakeholder interviews. We were fortunate to be able to obtain 16 virtual 1-hour interviews with individuals with clinical background, political experts, as well as individuals who are strong advocates within this field. I want to mention, for ethical reasons, we were unable to interview any veterans directly, although we were fortunate to be able to interview with many advocates and individuals who are representatives of organizations that communicate with veterans on a day-to-day basis, who are able to give us insightful insight into how best our recommendations could truly shape this platform going forward. We then followed through with a thematic analysis, which was founded through the data of our qualitative interviews, as well as those of multiple testimonials found through anonymous open source forums. Through this approach, we really wanted to make sure, as 4 individuals without military experience, without family with military experience, that we were able to enrich our understanding involving in this project. So to be sure that we had an understanding of all perspectives within this field, we involved in this analysis to make sure that different perspectives were considered. And as we approached our recommendations, they were multidisciplinary and ones founded on multiple different perspectives. Into our last approach of the 4, we considered different jurisdictional considerations on an international level, leaning back into that academic systematic literature review, as well as meeting with individuals of international expertise within this area, helped us shape our recommendations going forward to learn more about different policies and procedures that are going on an international scale that may be applicable in instilling in this PCVRS program.
Thanks, Bianca. So using the aforementioned methodology, we were able to kind of complete our analysis and identify 8 main key insights that were used to inform our recommendations and next steps. We've organized our recommendations within 3 different buckets, one addressing issues at the systems level, one at the clinical level, and one at the public level. Starting off with the systems level, we identified 4 main key insights that informed our recommendations under this bucket. First, we identified that poor collaboration between Veterans Affairs Canada, or VAC, PCRS, and different advocacy groups weakened holistic care for veterans. Stakeholders consistently reported a lack of coordination and shared practices, making the system difficult to navigate. A lack of transparency and accountability within the PCRS model also undermined trust with veterans. There was delayed services, unclear communication, and an exclusion from consultations that were recurring concerns amongst clinicians and veterans. There was also poor dam management strategies that eroded trust even more with veterans and re-traumatized veterans through repeated assessments and inconsistent access to their own medical records. Lastly, we also identified issues with geographic disparities, where access to services were limited in rural areas that led to, again, identifying or informing our recommendations under this level.
Now highlighting our systems level recommendation, we went with a 3-pronged approach to approaching this recommendation. Beginning with the first, adopting a universal definition of a veteran, ensuring that individuals, despite their background or military experience, were encompassed within this definition. As of today, Canadian Armed Forces, as well as VAC, define a veteran as an individual who has completed basic training and was honorably discharged. Although, throughout the different federal programs, this definition has various different interpretations, as well as other parallel organizations, partner organizations, such as Pension for Life and the Veterans Healthcare Regulations tend to use differing definitions, which provide disparities within services, as well as access to services that individuals may be able to obtain. In ensuring that we're able to instill a universal definition of a veteran that ensures individuals equitable access to different types of care and ensures that individuals aren't felt segregated by this system is of utmost importance. Moving into our second recommendation, establishing clear accountability measures is also of key importance. We want to make sure that individuals, not only just clinicians, but also VAC as well as CAF, in addition to veterans case managers, are aware of their responsibilities and are held accountable when those responsibilities are not met. Ensuring that there's transparency between each individual that is within the veteran circle of care and is acknowledged of their own responsibilities that themselves must uphold and those working in collaboration with them is also something that will help to bridge the gap on the systems level that we look forward to PCVRS taking on. Moving into our last recommendation, developing a secure as well as centralized data management system. We've heard from our stakeholders, we've read through the research that there is significant ethical considerations that are not met through this data management system. We want to ensure that veterans, when sharing sensitive, confidential information with their provider, is safe, secure, and kept to only the provider at all times. We want to make sure that individuals in disclosing this sensitive detail feel safe at all times and are able to be comfortable with their provider. We have heard cases of different testing results as well as different demographic data being accidentally put in the incorrect veteran patient profile, resulting in providers not under that veteran circle of care having access to sensitive, confidential information. Ensuring that these databases are secure and the right provider has access to the veteran profiles that they only need is of utmost importance in building a more safe, secure, and centralized data profile.
So how do we go about implementing these system-level costs? We're asking the federal government to really improve the universal definition of the veteran, to establish clear accountability, and to strengthen data management, mainly through investing in human resources internally within Veterans Affairs Canada. So to do that, we are asking the federal government to put in place a multidisciplinary committee to create a consultation process for veterans and practitioners and create that feedback loop that allows for veterans to have more of a voice within the system-level recommendations and improvements that are necessary, as well as creating and investing in an external evaluator, putting forward an RFP, and creating annual program reviews for the system that is clearly lacking. We also are recommending that they develop clear data protocols and they invest in the human resources needed to make that more consistent across the board. So these recommendations tally to a total of $2,500,000.
So when developing our clinical level of recommendations, there were really here four main insights that really informed gaps within mental health care, both in the availability and accessibility. In particular, we recognize that there is a presence of a very decentralized healthcare system, which is significantly disrupting the continuity of care for veterans and military families. With the provincially regulated healthcare system, it leads to a very fragmented national healthcare approach to veterans. And with the administrative burdens introduced by the PCVRS's model, it overall makes it difficult to access consistent team-based support, especially for those with complex mental health issues. There's also inconsistent mental health training, which is harming veterans significantly, where PCVRS's lack of a standardized trauma-informed care risks inadequate or even damaging support for veterans who are accessing their care. Geographical disparities are also apparent through this recommendation, where veterans who live in rural areas face greater health challenges with virtual care, which is often considered inadequate for treating more serious mental health needs. And we also identified that AI might be a potential and emerging opportunity to improve access and reduce stigma, as well as support early intervention in veteran mental health care as well.
Moving into the clinical level considerations. So it is essential that systems designed to provide care operate with clinical efficiency, consistency, effectiveness, and ensure timely, equitable, and evidence-based services that uphold the dignity and complex health needs of veterans. So what we're aiming for here is increased practitioner competence in veteran-specific care, more equitable access to mental health services across the country, as well as improve veteran trust into the PCVRS service providers. So the first recommendation is about mandating team-based, patient-centered care coordination by clearly defining roles and also streamlining collaborations between the different stakeholders. So the institutional approach of PCVRS is not systematically trauma-informed, and care is currently fragmented. Professionals do not have the proper channels and clearance to communicate together and work together to help veterans. Issues associated with this current clinical fragmentations are not limited to inefficiency. Veterans can be re-traumatized, abandoned in transitions, or forced to undergo the same evaluation and tell their traumatic story over and over again when systems do not know how to speak to each other. PTSD is also perceived as a condition that can be cured in months rather than a condition that it persists over time, and so veterans are pressured to heal. When our first recommendation is implemented, we're looking at interdisciplinary care frameworks adopted across jurisdictions. More streamlined and integrated care is safer for veterans. It encourages them to open up when needed and also allow for them to trust that help will follow accordingly. Therapeutic alliance is key here to healing trauma. We need to encourage a people-centered approach that recognizes the complexity of the clinical cases. The second recommendation is about standardizing case management and referral pathways across jurisdiction, ensuring that veterans have access to timely and trauma-informed care. Now, depending on where you are situated, you may wait up to a year and a half to access care. Canada's approach remains largely grassroots, driven by veteran-led nonprofits, local chapter, and community organizations, and it is currently fragmented. Case management varies across the country, with some veterans fast-track into wraparound services while others wait for months. Interviews reveal inconsistencies in how veterans are assessed, referred, and supported across regions, and even between case managers. Some even have virtual options only. Studies and clinicians keep saying again and again how in-person counseling can offer structure and connection that are both fundamental for healing and for building self-determination. For this recommendation, we're looking at equal access to proper care. We want an integrated network, not only in theory, but also in practice. This community of practice has to reach a balance between grassroots efforts and institutional support. The US, UK, Australia, they have embedded veteran-led peer support and clinician peer mentoring, and they embed all these services into the clinical basic services with formal structure, national funding, and certification pathways. We can do better. The last recommendation is about fostering a culture of continuous learning and resource sharing by promoting that all federally contracted practitioners complete military cultural competency and trauma-informed care training. As of now, specialization is up to the practitioner. There is no specific training beside a short module offered by Veterans Affairs covering the very basics. Veterans face precarious situations and uncertainty about where to turn to for adequate mental health support. Providing mental health care to veterans is challenging. Practitioners must understand the realities of the Canadian Armed Force and the complex trauma that come with military experience. Clinicians and stakeholders support that it's not enough. PCVRS should support professional development, and the government should ensure dissemination of good practices. One promising initiative in Canada is a think tank called the Atlas Institute, and they currently work on building knowledge, sharing resources that can actually support clinicians as well as veterans and their families to access proper health care and also live a smoother transition to civilian life. So we're looking at practitioners systematically trained in veteran-specific trauma-informed approaches. And one good practice is in the US, they created the STAR Behavioral Health Provider, which is a community of licensed civilian mental health providers who are formally trained in military culture and best practices. I would conclude this section by saying that veterans gave their life to serve us, and it's our turn to serve them with proper clinical care and support where they feel safe, seen, and in control of their healing.
Thank you. If we want to move towards a more human-centered approach, we need to invest in the human resources to make that happen within the government. So our recommendations and implementation plan really focus on creating more resources within government to connect CAF and back and to include the healthcare providers into this process. We want to invest in models that emphasize the veteran practitioner peer mentorship program model, as well as creating systems for assessments, for better referrals, investing in specialized training, so that the people that are interacting with veterans actually have the skill sets to do so. These costs are delineated as such on the slides, really focusing in on mandating the team-based care, case management, specialized training, and all of this concludes to a total of $2,841,000.
So our last bucket of recommendations focus on the public level, particularly Insight 3, where we identified that there are harmful public misconceptions about veterans, especially around the mental health care, their mental health care and the care that they are looking to access, that's leading to limiting in funding, increasing of stigma, as well as leading to policy inaction. So really here, our research highlighted that harmful misconceptions of veterans are pervasive throughout Canadian media. We've seen that over 60% of PTSD-related articles are focusing on the violent natures, the dangerous behaviors and criminality of veterans, while only less than 5% of suicide-themed articles provide any sort of helpful resources for veterans within them. And so this essentially kind of identified to us that there is a skewed portrayal. When it's combined with a lack of public data or public indifference, it really contributes to a sense of stigma, isolation, and worsened health outcomes for veterans. And so here we have two set of recommendations under the public level aimed at really just addressing the widespread misunderstanding of veterans while also trying to address the stigma surrounding their mental health. And so these recommendations are designed to foster empathy, reduce misinformation, and ultimately improve their health outcomes for veterans across Canada. The first recommendation here is to increase funding for public education initiatives that directly challenge harmful stereotypes while also integrating military service and these kind of concepts within the Canadian culture. So really here we're looking to fund awareness campaigns, media partnerships, and school-based programs that reflect the lived experiences of veterans. And for example, here in Canada, we have something called the Veterans Channel. It's a multimedia platform that works to essentially integrate wellness and transition-focused content by veterans for veterans into the media. However, many stakeholder interviews have identified that funding is significantly limited within these kind of initiatives. And so for us, we were hoping that strengthening this platform as well as others like it can help reduce or build national capacity for cultural change. The second recommendation we have here is to implement targeted educational initiatives that really work to raise awareness and reduce stigma. This means partnering with schools, community organizations, local governments to support veteran-led storytelling projects, curriculum development, as well as mental health literacy programs. So one promising model is the US's Veterans Legacy Program, which is a program that essentially connects national cemeteries with different community and local-based organizations to integrate veterans' stories into classrooms through partnerships with K-12 educators and other universities. And the program has already reached over 15,000 students, sharing over 2,500 stories of veterans to really just demonstrate strong educational and community engagement outcomes.
So to raise awareness about veterans' reality, the federal government must invest in creating these funds. So creating funds that are available for schools, for community organizations to create these types of national awareness campaigns and projects across the board, as well as investing in human resources within the government to build those connections between government departments and schools and community organizations. So investing in stakeholder engagement, community development, partner engagement, and those costs obviously come with an investment in human resource within Veterans Affairs Canada, as well as, like we said, making available pots of money for community organizations and schools to apply directly to get these types of initiatives off and running. So this tally would total $3,697,000 as an investment.
Given that the government implement all we just presented you, one very inspiring person told us that without conversation, there is no resolution. And I think it is so important to look at that in the short term and start with strengthening collaboration and bridging fragmentation so that we're all on the same page and we can more easily implement other recommendations. And so in the short term, the focus should be on laying the groundwork, standardizing definitions, strengthening coordinations between the different stakeholders, and enhancing practitioner training. These are crucial to improving access, transparency, and trust within the system. On the intermediate term, we're looking at foundational reform more in place and medically released veterans experiencing more consistent mental health support and smoother transitions into civilian life. Engagement with rehabilitation services is expected to rise, and disparities in access, especially for rural, remote, or equity-deserving groups, beginning to slowly narrow. On the long term, so 5+ years, the goal is a veteran care system that is trauma-informed, culturally competent and safe, equitable, and responsive. This includes not only stronger clinical outcomes, but also better system navigation, higher trust in institutions, and more sustained support for veterans and their family. Another very inspiring quote we heard was that someone said, "There are 1 million doors and we do not know which one to knock on." The idea here is to make that way clearer. The ultimate outcome is that Canada can and will be positioned as a global leader in veteran mental health care, recognized for setting a new standard in integrated, collaborative, and compassionate service delivery.
I'd like to end us on a quote. We had one of our stakeholders speak to us about the future outcomes of veterans, and he said, "We want to work now not only to address the past and the present, but also the potential future, because another war seems looming. And I, the stakeholder, want to make sure support is in place to ensure veterans of the future are well supported." The recommendations that we've put forward in this brief really focus on improving the system that is clearly lacking, improving the quality of care that we're providing our veterans and future veterans, making it more human-centered, more holistic, and to have the specialized training to pull that off, as well as creating more awareness across our beautiful big country of our veterans and their reality. And so those recommendations that we've put forward tally to a total of $9 million for the first year as an investment, which is quite small in comparison to the $560 million that has already been invested into the PCVRS contract. So it's a 1.6% increase. We seek to build capacity for a system that honors the service with the compassionate, effective, and high-quality mental health care our veterans deserve. And we hope you've enjoyed our presentation.
Thank you. Thank you very much. Interesting combination of issues that are very much on the public agenda right now. Lots of focus on the armed forces, the future of the armed forces, but also that common issue we find in many policy labs where you have a level of public service, health and mental health, which is under provincial jurisdiction. So lots to needle with in that policy lab. So I'm going to hand it over to the jury. It looks like Kyle is going to go first. You can get your questions ready. We will go to our sponsors first, though, before we come to the general audience. Okay, jury, you're up.
Thank you. A wonderful presentation. As someone who's worked with a lot of veterans who've been deployed to peacekeeping missions in Rwanda or the Balkans in the 1990s, to Afghanistan, to our short deployment to Mali. I've seen firsthand how veterans have suffered from mental health problems, higher rates of suicide, drug abuse. I mean, it's frightening to see how many Canadian soldiers were deployed abroad and had no support, and that we're finally having this discussion. So I thank you on that. I also like how you costed out some of your recommendations and priced them, and I think that's important to have, to realize what kind of resources you're trying to push in the system. One thing jumped out at me, and I didn't hear, but maybe you could explain. There was talk about referred pathways across jurisdictions, and you also talked about enhanced coordination between healthcare providers. And the reason I bring this up is that I understand Veteran Affairs Canada has responsibility for veterans, and you referred to this urban-rural divide. But the reality is that in Canada also, the provinces provide healthcare. So I'm curious, in your discussions with veterans or other groups, was there any talk about parallel programs or any support from the federal, provincial healthcare services to help veterans, or is that simply something that the provinces don't want to touch and are leaving the Canadian government all alone? I'm just curious to know how that coordination happens, if it is at all an issue that came up in your discussions.
It is such an important question because, as you know, healthcare is a provincial jurisdiction competence. And so when we were looking at this issue, we were wondering, where is the breaking point? Like, what happens when a veteran is medically released and can finally access PCVRS? And what we realized is that in some regions where you have a bigger concentration of veterans, you have access to more integrated and easy services, so you can step in one place and receive different types of care. And when you were looking at other jurisdictions, for example, more in the north, where you have a bit less veterans than, for example, Pembroke or Ontario, you get to realize that it is way more difficult to work, for example, with provinces or even with municipalities to be able to bridge this breakpoint and offer proper access. So yes, to answer your question, we looked at that, and we also looked at how the different types of services can sometimes be stacked one on another. So for example, a veteran will go into an evaluation, and they will suggest XYZ care, and instead of thinking globally how it can benefit the veteran, they will try to make this person go through it as quickly as possible so that they can release this person from the program completely. And so there is no strong collaboration or holistic approach to health here. And what we're trying to bridge is, making people talk, having a dialogue on how we can make the different levels of governments or even different providers work together so that you don't go to therapy in the morning and get a massage in the afternoon to release the stress that your therapy brought up. And then you go again in another different type of therapy right after, and it kind of brings it all up. So we have different types of problems we're trying to sort out here, but the jurisdictional considerations are very important, and people need to be willing to work together.
Okay, thank you. Excellent study. Very interesting. My experience is with cancer care of cancer patients rather than with veterans. But it seems to me that for serious medical and psychological cases, about maybe half the time, the real care coordinator is a family member. And you just don't get away from that, no matter what effort is put into formal care coordination. And often there are real benefits from at least the 50% of times or whatever it is that a family member is taking charge. They may themselves need services, but they're also being the coordinator, tracking the meds, the appointments, keeping a notebook, following up on everything. And patients with someone doing that beside them are way ahead of the patients who don't. And the caregivers, the professionals, really, really appreciate having that person there. It makes their job easier, and it buys better service on every level. And that frees resources for the people who don't have a family member who's taking care of them. So my question is, although, in immigrant settlement, for example, when you have a friend helping the immigrant settle, you can train the friend to be an advocate and to be a supporter for the first 2 years of the immigrant settlement. And at a very low cost, you get a trained community member who knows how to do that. Is there room, do you think, for training, for designating, training, and supporting family members or volunteer advocates to go along with these people without drawing away from the professional case coordination?
I think that's a really excellent point that you've just made in terms of, saying that people who have the advocates next to them are actually reducing the overall cost, essentially. And so we did effectively, the veteran community and the veteran community advocate organizations often very much bring in the family into the therapeutic alliance and therapeutic discussions. Veterans Affairs Canada has a specific kind of budget allocated to supporting the families of veterans. We also looked into, in the US, there's a model of, it's the US Caregiver Support Circle. And so they have a model there that's quite effective, as well as kind of taking in parallel what you just said to apply it to a peer mentorship model. So having other veterans who have already gone through the system be the ones who can directly relate to people who are just starting to figure out how to navigate this ecosystem of services. So we spoke to many advocates who suggested that as the kind of the best way forward. One of them explained it as, you're coming out of military service and you're dealing with all of the things that have just happened to you, and there's a black veil of fog in front of your eyes as you're trying to look at this sea of services and supports. And so having somebody right there beside you who has literally just experienced the same thing is like the highest recommendation that came to us from all of the people that we spoke to.
Anyone else want to come in at this table? Brenda.
I don't know how to ask this without without sounding critical. So just kind of take it as not meant to be critical. So
Sure.
PCVRS got $560 million to do a 5-year contract. And without knowing exactly what was in the RFP, it would seem to me that a number of the goals would have been the same as exactly what you've proposed here. So I'm wondering, what it is that will be different, how you'll go about taking something that was designed to do exactly what you're talking about, I think, and now what will make this different from kind of what failed in the first instance. And I'm not looking, as I said, for you to throw PCVRS under the bus. It's really what's different now that's going to make the same goals with a really small amount of money in the scheme of things, $9 million over 560. What's going to allow this to be successful when the first 560 million wasn't?
Great question. And I think in terms of drawing your attention to the price point that we've pitched kind of as a first step to that 560 million, in terms of the timeline of this contract, of the PCVRS contract that we'll all agree not to throw under the bus, there's only about 1.5 years left of that contract. And unfortunately, in terms of transparency, and that's why we focused in on a lot of, in terms of accountability, there has been little to no information on the progress they've made on any of their key performance indicators or the original kind of objectives at the core of this. So there's a huge lack of transparency to be able to answer that first part of your question. And we're hoping that what we've put forward as recommendations can, it always depends on how fast government works, right? If they can kind of put some of these recommendations in the last year. And in terms of, what's the difference between the PCVRS and our recommendations, I think we've really focused on improving dialogue between the different stakeholders involved, whereas PCVRS had the idea of bringing together vocational training, medical, and psychosocial, but they didn't think about the partners in each of those different entities that would need to work together on the same kind of objectives. So they missed the piece where they have to invest in how to connect different people. And putting kind of theory into practice is what we've really focused in on, and hoping that will be a bit different to PCVRS's initial kind of mandate. And my teammate has highlighted connection in big capital letters. We want people to connect, because if everyone works in silos, nothing gets done.
If I can add to it, I also think that one strong insight we gathered was that PCVRS, the program was built on very low consultation. So we would encourage going forward more consultation processes with the communities, because mental health services existed before PCVRS and they will continue to exist. But we need to create this connection also with the communities that were already working to help veterans, as well as veterans themselves, who are the best people to know what they need to properly heal. Yeah.
Anything else from the jury? Can I turn to our two sponsors? I'm going to pass the microphone back. We'll give you the first word before we go to the audience. Can you just introduce yourselves for us? That'd be great. Superstars.
Hi, my name is Dr. Alicia Henson, and I am Pembroke Psychological Services. And first of all, amazing. This has been really great. I really appreciate everything. As far as questions, I have a lot, and we'll probably continue to chat after. But I guess the biggest question on my mind is, with regards to PCVRS having a year and a half left in the contract, based on all of the things that you've pulled together, what do you think is the fundamental first step in bringing some of this to fruition?
Yeah, thank you so much, Alicia, for that. And also thank you so much for your guidance throughout the project. I think if I can think back to just our crafting stages of the recommendations and reviewing all of our notes, not only from the qualitative data, but also the quantitative data, I really think at the core, the priority should be at the clinical level. This team-based integrated approach that really does leverage different providers, as well as reaches for different advocates and enhances veterans' voices, I think is of utmost importance in trying to make the best of what we've got with the year and a half that's remaining. Making sure that all providers are in the loop, making sure that data is being able to be handed off to different providers as they do move through different providers or transitions to different case managers. I think that tying up any loose ends within that clinical component is something that we should really be prioritizing in this last year and a half that we've got.
I'm Natalie from Valhalla Vision's Counseling Clinic in New Brunswick, and I want to say that leadership is showing up for the team and setting people up for success. So the four of you today are really standing up for the veterans who are experiencing an absolute famine to be heard. So on behalf of those who are in that position, I want to ardently thank you for that, because they need it. They've done enough for us. They've gone and done things that we could never even think of, because we're away from it. We don't have the same things occurring like in other parts of the world. So the work that you folks have done in a very short time, when it's taken years and years to get the research that we've had and the stuff that Dr. Henson and I have been doing for a long time, outstanding. BZ or Bravo Zulu from military. I'm not kidding. There is such a love right now. One of the people who you interviewed is a UK veteran. He's in Bulgaria right now watching. That's how much he appreciates the work that you folks have done in this project. So I can't thank you enough, because I chose the name Valhalla for my clinic because if anybody knows about the Viking history, it's a place where people go to rejuvenate, right? Mm-hmm. And this is the example that the four of you have put together very beautifully for that. So again, leadership is about learning, refining, and developing. I think you've done an absolutely beautiful job. So my comment or question, I guess, is throughout this process where you came from an area of no military background, family, anything to do with this specific community, what stood out to you as being the most memorable moment or touching or just wow, it could be anything.
I think there's a lot of things I can say to that question. I think I speak on behalf of our entire group, and I say that the community aspect has been really the standout for us. Seeing how encouraging supportive everyone has been throughout this journey, recognizing how complicated the issue is and how overwhelming it might have been for us to kind of start this journey and be able to kind of distill through all the information that was thrown at us, recognizing that everyone that we talked to, all the stakeholders, were just so supportive. They wanted to see us succeed. And sometimes people were scared to stand up and say something, and really took the opportunity to kind of be our cheerleaders and be able to support us through this journey. And so I think for me, the community aspect and being able to just know that we have an army behind us to support us through this process has been definitely the most rewarding.
It's okay.
I'm going to open it up, but just while you're thinking of your questions, I just had a quick one sort of from left field. I think it's today or yesterday. We heard we might be spending $150 billion on our defense budget. So I don't know if that's exactly the right number, but let's assume, what did our Prime Minister say? That's a whole lot of money. What would you say if you were talking with the Minister of Defense or other cabinet ministers about how we should spend our money in this domain? Do you see this as an opportunity, and what would you say? And then others, please think of your questions.
Yeah, so I think that investment was in response to the NATO 2% increase. We were fortunate to actually have a question related to this one in our practice presentations, give us an opportunity to actually dive into this further. In reviewing the NATO policy, unfortunately, rehabilitation is not included within that protocol. So in reviewing that, we do see that this is a really critical component in not only making sure that veterans are doing well throughout their time serving, but also have something to look forward to in terms of care and support once they are honorably discharged. So I believe that the spending is a great investment, but unfortunately, it does not integrate that rehabilitation component.
So maybe we should change it.
Yeah, NATO.
Or advocate for it. Other questions? Yeah. And we've got one online, but I'm going to go to Diana first.
And maybe just while we're setting the question, I'll just also specify that, we've created this policy brief for Pembroke and for Valhalla, and we've also created an advocacy guide to help them leverage the next steps to take this to government to get some traction. And also it's been shared with all of our stakeholders that we interviewed, and we've also created questions to capture their insights. So this is phase one, we're hoping, of creating some momentum and change for this particular issue.
Hello. Thank you so much for your brilliant presentation and for doing all this work for what is usually a very underserved community. I was really struck by the fact that a lot of your recommendations were equity focused. And I'm curious to know about the research that you found in terms of maybe disparities and demographic differences that amongst veterans and the kind of care that they receive.
For sure. So, admittedly, data is very limited in all kind of aspects of this field, where census data was only collected I think, 4 or 5 years ago. And so we have a very limited number of, demographic data that's available to kind of take on more of an intersectional lens that we kind of wanted to take on in this project. When we were looking at the data, we saw that visible minorities, women, veterans from LGBTQ plus communities were at a higher risk of certain conditions, whether that was PTSD and things of that nature. And so we wanted to be able to dive in more and kind of take even more of an intersectional lens when it came to developing our recommendations. Unfortunately, that data was not available. And so we've kind of used that as a future or a next step in terms of being able to advocate for a more transparent, more available data to ensure that we can more effectively integrate these kind of frameworks into our recommendations. But we do recognize, as you mentioned, that this is a very underserved, very diverse population. And so we want to, again, make sure that we're doing justice in ensuring that all aspects of the care are kind of accounted for and all disparities are accounted for. But yeah, again, we're just going to hope that there's more data available and kind of push that forward as a next step in ensuring that we address all these issues from a holistic perspective.
We have David Tyndale. We see your hand raised. If you want to unmute yourself and pose your question.
We're ready for you, Dave.
Can you hear me okay?
Yeah, we can, Dave. Thank you.
Okay, I'm currently just stood by the beach in sunny Bulgaria, a couple 100 miles away from Ukraine at the moment of all this. First, I want to thank Natalie, who I've known for, over 12 years, before she'd even thought of setting up Valhalla. And thanks to the introduction to Dr. Hansen. We've got another gentleman online currently in Antwerp as well, a British veteran called David Heavysides, who we work very, very closely together with in the United Kingdom. An organisation is called Changing Step Northeast, which has given veterans a change of direction with the mental health and the transitional support services. And David runs his organisation called Veterans Activities for Mental Health. We get people out there to engage with all sorts of physical stuff and everything as well. So that's the background with me and Dave, who sat on the call. One of my roles within the UK, I'm one of the 2 project managers for the Veterans Mental Health Network for the National Health Service and Operation Courage. And when we spoke to not only Natalie and Dr. Hansen, one of the things that we seem to have in common with looking at things, and I keep bringing it up in the UK, is having programs like we do in the UK, Up Courage. And the question I keep raising at all our webinars within the health service and the Veterans Network is, it's okay having one of these programs that help veterans, but what platform is being used to get it there? The veterans know it exists. And as you've mentioned in your presentation, which was fabulous, by the way, well done, guys, for all the time and effort, that roadmap or that route map to let veterans know how they actually access it is one of the big failings we have in the UK. Would you see that as a route that whenever something's implemented in Canada, of how you actually get it out there to the veterans? I don't know if you have a better system than we. VA in America, I work with them as well. However that route is to get it out to the masses, not the minority, and what sort of route map to basically explain to us veterans where we are that used to being told what to do, when to do it, and where to do it, that if there's a complete clear guide saying, you need to do this in this route to do this to get this result, would you feel that that would be something that could be implicated within your own Canadian services?
Okay, thank you so much, David. So there's a question here really about access. So if you build it, will they come? How will they come? How will they know about it? Particularly given culturally, there's been a lot more direction, which you talked a bit about in your presentation.
Thank you, David, very much. It's nice to hear your voice again. We actually spoke to a kind of a specialist in mapping services called the Challenge Factory here in Canada, and they've mapped out the services that a veteran accesses once they transition from military to civilian life. Specifically, the one that they had mapped out was the services that they used to seek employment. So the employment services, the different steps along the way. So we spoke to them to get an idea of how they would go about doing that. And again, the suggestion came up, and I think Dave, you suggested this as well to us, in terms of really emphasizing the peer mentorship model of having somebody support you through that navigating that ecosystem and that process. But I think that you're right. I think there is a need to develop a true map of the services once somebody in military service exits and transitions to civilian life. There is a disconnect. There are people who know certain services. There are people who know what forms to fill out, but across the board, there isn't like this map to tie everything together. So I think that one of our recommendations is to kind of encourage that conversations between different stakeholders so that we can create a mapping system for a veteran. Do you want to elaborate?
Yeah. I would just add one thing. I think services should not start when you leave the military. It should start way before, if not when you get in. And those services could look like education initiatives, so you know what's waiting for you when you step out, as well as education on how can you self-assess some of the signs and symptoms that you may be undergoing very difficult trauma, PTSD, and so you can go by yourself, reach for the help you so desperately probably need after seeing awful stuff. And so this is one of the main things. The second thing I would say on that question is it's a lot about education. We talked about providing a lot of funding to increase the public awareness. But we also need to understand that the veterans themselves are undergoing such a big stigmatization around mental health needs that they may themselves not even be able to accept that they need support. And there are a lot of empirical models to create interventions and educations that will target some behaviors and attitudes toward mental health that we can actually use while in the service. So when they leave, they actually have the tools and the resources they need to properly self-assess and understand the environment they're in.
Okay, I think we've got time for maybe one more question. We'll see on our time. Emily, yeah.
Great, thank you so much. Is that coming through? Congratulations on a really inspiring and compelling presentation and project. It was a real pleasure to listen to, and I really appreciated how you really brought in some of the voices of the people that you spoke to. I have two questions about the recommendations that I was hoping to just learn a little bit more about. Firstly, at the clinical level, I was hoping you could say a little bit more about the potential applications and uses of AI, but also some of the risks and potential pitfalls of that. And then also at the systemic level, and piggybacking a bit on Diana's question, what does structured veteran input into evaluations look like, particularly given the diversity and some of the challenges you note in the presentation look like?
Okay, I'll touch on the first one. Thank you so much for your question. As you've seen in the key insights, we definitely covered artificial intelligence as presenting both opportunities but also challenges to this issue. And when we started diving into, well, what were the impact of using AI, we got to understand it was a full project in itself. And so we kind of included it in our next steps so that people can actually take a deep dive into what it means to use AI. Because when you look at implementation plans and action plans at the Veterans Affairs Canada, you see that they have the intention of harnessing and fostering AI use with clinicians. And so what does it mean for veterans? Well, it can mean that you kind of access a one-size-fits-all type of service and it's not necessarily adapted. But for clinicians, it can be an interesting tool to push the reflection further. So if you're in front of a difficult case, for example, AI can be interesting to bring some important questions, but it should never answer them for you. And I think that's the stance we're taking here. We see how it can help because AI is a huge pile of data, but also when we're talking mental health, we're talking human, we're talking connections. And so we cannot rely on artificial intelligence, to make our work for us and see the human behind the data that kind of defines them in their evaluation. So I would say this is one of the big pieces about AI, but we do have a lot to talk about. So if you want, we can talk some more.
Yeah, just to bridge into your second question, but just closing off on the WEMIs. All models are wrong, some models are useful. Artificial intelligence has several significant gaps with it, ethical concerns as well in the clinical setting, not just exclusive to this area. So AI, I don't see personally ever replacing the role of a clinician or provider within this space, potentially aiding in some way, but that's going to need to be at an arm's length at all times. Bridging into your second question about that systemic approach, specifically with equity-deserving groups, unfortunately, the data here is very, very scarce. Very little data in terms of folks who do identify within these groups and their experiences within this model. We've heard within different stakeholders longer wait times as well as lack of culturally competent care, not only within that veteran experience, but also from like an ethical, cultural, religious standpoint as well. So making sure that providers within that are also able to meet individuals' needs, not only from that veteran experience component, but also from a personal standpoint is something that should be instilled within this program. Speaking to your question on feedback, this is something that came as a very big shock to me, that there isn't really a channel for clinicians or providers to provide insights, suggestions for feedback, but also discrepancies within the program. The coordination between clinicians, providers, and the case managers is somewhat disjointed at times. There's not so much a direct channel of communication. As well, when things tend to go south, there isn't a direct path forward, and there is disjointed channels of communication. So within a program evaluation, organization model that was recommended within our second of 3. I think that this would really highlight the greater disparities within this program, particularly within communication across the board, and also highlight that qualitative, quantitative data element that can really enforce a positive feedback loop for change forward for those who are severely underrepresented within this program, continuously lacking care as well. Our veterans have served us for long enough, so it's time for us to give them the care that they desire and deserve.
Okay, I think we are going to, oh, you have a question? There's one more.
So before we give the final clap and congratulations, both Dr. Alicia and Natalie have something they would like to share with you. Do you want to take the mic and go up to the front?
Sure.
Okay. All right. I'm up first.
We all need help. Yeah. Everybody needs help.
All right.
Okay. Nobody cry. Oh, she's a really big bag.
Oh.
Oh.
Oh, wow.
You go first.
All right. I just have little gifts for the team. A thank you. These are in support our troops. It's an organization where 15% of all the proceeds go back to veteran care. So I wanted to give you guys a thank you, and thank you for supporting our troops, and which also helps support veteran mental health and well-being. They help provide a lot of services for people and their families, veterans and their families. So I wanted to just give you these and little thank yous. Thank you. Thank you so much, guys. And thank you on behalf of veterans. I found the presentation very moving, and I think that they would as well, because they need advocates, like you said. They've been doing so much for us and to make hopefully the world a better place. And so when they come home, let's take some of the burden and help them. So thank you.
Yeah. Do you want to help me out with something?
Yeah.
Okay, so can you take out the first and just kind of open it up and display it?
Oh.
So I actually was thinking about like graduation gifts for the students. These are my clinic hoodies. I designed the back. So this is the front. They knew they were getting them, but they didn't know when I was going to get them. So I got permission beforehand. So these are 3 runes here. Courage, warrior, and spirit. So the motto for my clinic is fortify the warrior within by finding the courage to reclaim your spirit. This is what this demographic needs. Each clinical hoodie color represents a different style of leadership. So.
Talking to the mic.
Talking to the mic? Okay, is this better? Okay, I apologize. So, first up, we have Clea. Clea. Black represents directional leadership. She's a stellar example of that within this project. It represents a tempered command of leadership. It's not authoritarian. It also represents protection, elegance, sophistication, and appreciation to details, to high-quality work, organization, and rationality.
Wow.
White represents spiritual leadership, another component that this demographic really, really needs. It encompasses a holistic view and ensures safety, including standards and expectations, ensures and promotes personal growth. It also symbolizes protection of the spirit, mind, and body, which is also a very soulful and grounding experience. Come on up, Noémie. Noémie, Noémie, Noémie. Yes. Bianca. Come up, my dear. Navy hoodies represent organizational leadership. Analytical, organized, trust, including boundaries, and the modeling and application of mentorship. Congratulations. Oh, okay. Al. Your turn. What? Blue. There's only 2 left. Okay. Another Navy hoodie for organizational leadership. Bringing change and leadership, including wellness to teams. high quality achievement seekers, security, loyalty, reliability, and responsibility.
Thank you.
And last up, that one's yours. Another navy blue hoodie, which is also the color of Odin. Navy blue is Odin's color, so you all have cloaks from Valhalla. I want to extend an immeasurable compliment to my colleague who has given me advice, collaboration, professionalism that I've been absolutely starving for while working with this demographic, because you don't always get it in anywhere that you work. So again, I'm extending my appreciation for her by also giving her a hoodie. Okay?
Great. Well, this has been a wonderful collaboration between sponsor. Where's the coach? Coach is Leslie. And Clea, Noémie, Bianca, Al. Wonderful job. Congratulations. Thank you very much for coming in person and for these lovely, lovely gifts to recognize the different styles of leadership in the policy labs. So thank you so much.